Our next speaker is Dr. Luke Morris from Memorial Sloan Kettering, and he will present on early data and clinical trials for the treatment of HPV-positive head and neck cancer patients.
Thanks very much. So, early data from the clinical trials that are currently open or have recently completed for HPV-associated oropharyngeal cancer are pretty limited. That doesn't mean that we shouldn't talk about the clinical trial landscape for HPV-associated oropharynx cancer. I think if you think of clinical trial schemas as the distilled down version of the questions that we're grappling with in the field, you can get a really good sense for where the field is headed and the kinds of questions that we're going to have answers to in the next few years by looking at clinical trials that are currently opening. I don't think this is really the question that we're asking so much anymore. I think that you guys in the audience would agree that the answer to this question is that probably yes, there is some way in which we should be de-escalating therapy in patients with HPV-positive oropharynx cancer. So that isn't so much the question anymore as it is this one. How can we preserve the excellent local regional control outcomes that we currently enjoy in oropharynx cancer and de-escalate toxicity safely? And so I'll talk about a number of clinical trials around the world that are seeking to answer this question. For example, should we be de-intensifying systemic therapy? I'll talk about some of those trials. Should we be de-intensifying radiation therapy? Is that the solution? Should we be doing surgery and using that as a modality to de-intensify both chemo and RT? Should we be treating these patients with RT alone? Now, I don't want to give you the impression that the only game in town is de-escalation. It's really what I'm going to talk about because these are the trials that I have time to talk about. But Jose Basalga, if you saw his keynote this morning, talked about PI3 kinase pathway activation in HPV-positive oropharynx cancer. The TCGA data, the Cancer Genome Atlas data, appear to be showing a higher rate of alteration in that pathway than in HPV-negative disease, so that's an attractive area for currently ongoing phase 1 and phase 2 trials. The other very exciting area, of course, is immunotherapy. Immunotherapy is the biggest development in science in the past year, and this has obvious potential tractability in a virally mediated cancer, and so we're going to see trials with immune checkpoint inhibitors for HPV-positive cancer coming down the pipeline, but they're not opening now, so I won't talk about them today. Or are they more? Maybe they are.
Not yet.
Not yet. So risk stratification is what we are trying to learn and understand in HPV-positive associated cancer. This is probably the most commonly shown slide when it comes to talking about this topic these days, right? So this is from Dr. Gillison, Dr. Ang's paper in the New England Journal. But really the key figure is that one on the left. Using this recursive partitioning, this paper was able to identify different risk levels. And the HPV-positive tumors are those on the left. And you can see that those patients who had a less than 10 pack-year smoking history, or perhaps had a more than 10 pack-year smoking history but had only N0 to N2A nodal disease, were identified in a low-risk category. And so these are the people with a 3-year overall survival in that study of 93%, perhaps the most attractive cohort of HPV-positive cancer in which we might want to de-intensify therapy. Here's another way of looking at that. This is retrospective data from Brian O'Sullivan's group at the Princess Margaret. And these are patients, some of whom were treated with RT alone, some were treated with chemo-RT, and they were also able to identify a lower risk group who had better prognosis. 93% 3-year distant control, 95% 3-year local regional control. And they were able to tease out a group of patients who perhaps would be the ideal cohort for de-intensification. T1 to T3 primary, N0 to N2A neck, or if you had an N2B neck but were a less than 10 pack-year smoker, you also seem to fall into this lower risk category. This is data from Memorial. This is Nancy Lee's group, and doing a similar, again, recursive partitioning analysis, which is this sort of hierarchical clustering to identify risk groups, we see T1 patients falling into the lowest risk group. we see an intermediate group who also have quite good 3-year distant control. And look at that high-risk group. So not only is it T4 primaries, but it's also T2, T3, T4 primaries with low-level lymph nodes, which they defined as level 4 or low level 5 lymph nodes. Significantly different outcome. So those are patients who perhaps we would not want to be de-escalating therapy in. So I'll start with the RTOG 1016, which many of you have heard about for years. This was the first big national cooperative group trial to actually really be limited to HPV positive cancer, for the first trial to use that biomarker as an entry criterion. And this is very similar to other trials around the world. Down in Australia and New Zealand, there's the TROG 1201, there's the De-escalate HPV trial in the United Kingdom. And this is a trial comparing cetuximab RT with cisplatin RT in HPV positive oropharynx cancer. And here's the rationale for the trial. Could we preserve the same rates of local regional control but decrease toxicity? Mainly acute toxicity, which we had data indicating that we could reduce acute toxicity by potentially 50% by using cetuximab rather than platinum, perhaps also better long-term swallowing outcomes. So this is the trial design, and it's actually a very conservative trial design. It was a non-inferiority trial design where the primary outcome is overall survival, which is not the case in the other international trials that I compared this to. The primary outcome was overall survival, and what this trial is looking to do is to show that that bottom arm within a narrow confidence interval has the same progression-free survival as the standard cisplatin-treated arm. So close to 1,000 patients. The trial closed relatively recently. It will be many years before we have the data available to review because of the relatively small number of events that we expect to see. And so this is designed statistically to allow us to potentially make this statement at the bottom, which is if cetuximab and RT is non-inferior and less toxic, we would consider it an effective and less toxic alternative to concurrent platinum. So another side of the coin would be to de-escalate radiation therapy rather than systemic therapy. The ECOG 1308 trial, it was a phase 2 trial using induction chemo as a sort of chemo selection regimen to identify favorable or less favorable patients and then de-escalate the dose of radiation in those patients who seem to be doing favorably. And I'm going to show you some slides from Tony Similak's data that he presented at ASCO a few months ago. So this was the trial design, P16 positive oropharyngeal cancer. These patients were first treated with an intense induction chemotherapy regimen of docetaxel, cisplatin, and cetuximab. And if they had a clinical CR, they were then moved into this upper arm, this de-escalation arm, with a significant reduction in RT dose, about a 23% reduction, down to 54 gray. And they were treated with concurrent IMRT and cetuximab. If they had less than a clinical CR, they were treated with standard dose IMRT and cetuximab. You can see, interestingly, that in the design for this trial has already accepted that cetuximab is a reasonable alternative to cisplatin, right? So that's one of the very interesting things about this trial, also quite a dramatic reduction in the dose of RT. And so we have data to show you. So this is from the ASCO slides. First of all, the rates of clinical CR were high in the primary site and in the lymph nodes. That's the top row there among the patients who received induction, clinical response on the top and radiographic response down below. These are the endpoints. So the goal was to achieve 85% 2-year progression-free survival with this dramatically reduced dose of radiation. And within the confidence interval that's shown there, you can see that they were able to achieve that. It's 80% in the low-dose patients. I've circled in red those groups of patients in whom the survival outcomes were lower than for the entire cohort. So perhaps higher risk characteristics, T4A, primary site, N2C nodal disease, more than a 10-pack-year smoking history. You can see that the progression-free and overall survival rates are lower for those 3 groups. And so they've identified a favorable risk cohort in green there, the less than 10-pack-year smoker with less than T4, less than N2C disease, excellent 96% 2-year progression-free survival and overall survival. And so here are the curves So there's that outcome, less than T4, less than N1 to N2B, less than a 10-pack-year smoker. Perhaps the best or most favorable group of patients to take forward for further study and de-escalation. Now, those were patients who achieved a clinical CR to induction chemotherapy. And you can imagine the thinking that, that Bob Ferris and others had for the ECOG 3311 trial, which was, well, we can achieve a pathologically demonstrated complete response by doing surgery. So why don't we do that instead and then use that pathologic information for risk stratification? And so this is a trial using surgery for risk stratification followed by de-escalation or standard dose therapy. So this is the ECOG 3311 trial, which is now open, P16 positive squamous cell carcinoma of the oropharynx, T1 to T2, N1 to N2B. The high-risk group at the bottom, positive margins, gross extracapsular spread in the lymph nodes, 5 or more metastatic lymph nodes, these patients are not going to be de-intensified. They're going to continue to be treated with 66 gray of IMRT and weekly cisplatin. But in that intermediate group, that randomized group, that's where the question is being asked about whether we can effectively de-intensify therapy. So if the margins are negative, if there's either no ECS or microscopic ECS, up to 1 millimeter being the threshold that was chosen, 2, 3, or 4 metastatic nodes in the neck, PNI or LVI, these patients are believed to be in an intermediate risk group, and they're going to be randomized to either 50 or 60 gray of RT. So you can see we're even bringing that radiation dose down a little bit lower from what it was in the 1308 trial. 2-year progression-free survival, local regional control will be the primary outcome, and we'll also be measuring functional outcomes and quality of life. I'd like to show you a variant on that trial, which to show you how some other groups are pushing the envelope. This is from the Mount Sinai group across town. This is the SIRS trial, which Brett Miles is the PI of. And you can see that in that top group, surgically resected patients with even 2 positive nodes are going to go into a surveillance arm. No adjuvant therapy with 1 or 2 positive nodes, provided there are no other adverse features. You can see, in contrast, the intermediate group is going to be treated with 50 gray of post-op RT, and the high-risk group, which includes matted nodes, low-lying lymph nodes, which I mentioned shows up in our data from Memorial as well. The threshold for chemo-RT is also 3 metastatic nodes in the neck, positive margins or gross ECS. Those patients will be treated with chemo-RT. Note that the RT dose has been de-escalated to 56. One of the questions that those trials are not going to answer that is a topic of much discussion in the field is what is the relevance of extranodal extension in HPV-associated disease? And these trials are not able to answer that question, but Bruce Hoey at Wash U and collaborators at other centers have opened the ADEPT trial, which will take surgically resected P16 positive patients provided that they have ECS in the nodes, they will be randomized to either chemo-RT or RT alone. To my knowledge, there's only one randomized trial of surgery versus no surgery, and this is the Canadian ORATOR trial, which will actually randomize patients to a surgical arm or a non-surgical arm. Difficult to do, and anticipate the results of this trial. This is a quality of life as the primary endpoint trial. This is a very exciting trial. So this has just been approved. This is the NRG HN002. This is Sue Yom's trial from UCSF. This is a trial that is beginning to embrace this low-risk cohort, and you can see that this is limited to non-smokers, less than 10-pack-year smokers with locally advanced oropharyngeal cancer are going to be treated in one of these 2 arms. They'll be randomized to either 60 gray of RT with cisplatin, so that's a lower dose of RT with weekly platinum, or 60 gray of RT alone. And so this will be very compelling data if they're able to show non-inferiority, which is how this study is designed with these 2 arms. These are a lot of the patients who we're currently advocating for surgery for. Many of these patients, it could turn out, could be treated adequately with radiation alone. So this will be very interesting. So the final point I want to make is, that was alluded to by some of the previous speakers, is that I think it's fair to say that we all recognize that This is a virally mediated cancer, and we have a tremendous opportunity to embrace vaccination. As oncologists, we need to promote universal vaccination against HPV in both boys and girls. Surely this will eradicate and cure more patients, well, save more lives, I should say, than all of these clinical trials combined. Many of you know Professor Michael Gleason, skull-based surgeon from London, who's here in the audience. So his son, Mark, who is here in the picture, and 3 of his mates are rowing a boat across the Pacific Ocean. They're the little yellow boat in the upper left from Monterey, California to Honolulu. They arrive on Tuesday, 2,500 nautical miles for one purpose, which is to raise awareness of HPV vaccination. And what they need is our support, so I'd like to ask you, if you can, to pull out your phone, go to nomancampaign.org and sign the petition to encourage universal vaccination and end 5% of cancers that are HPV associated. I think that would be a great effort and a truly inspiring athletic endeavor. Thank you very much.